Good morning. I think we'll get started now. My name is Jin-Moo Lee. I'm the chair of the Department of Neurology. I'm delighted to introduce this Grand Rounds, and I want to thank Emma and the other organizers for Grand Rounds for including faculty from neurology and internal medicine Grand Rounds. I know that Daniel DeLuca presented several weeks back, and it's my pleasure today to introduce Brendan Ebi. So Brendan is a rare breed in neurology. He's an interventional neurologist, and we're just beginning to enter this field of intervention. And Brendan is a native of Alabama. He went to University of Alabama as an undergrad. He went there as a medical student, and then we were very lucky that he came here to train in the residency program here at WashU. He then went for fellowship training at Emory University, where he did both a stroke fellowship as well as an interventional fellowship. And then we recruited him back in 2021 to be part of this growing team of interventionalists. And so we have currently 4, soon to be 5 interventionalists across 3 different departments: neurosurgery, neurology, and radiology. So it's a truly interdisciplinary group. And this is the kind of the tip of the spear of intervention for acute ischemic stroke, and we're going to hear all about the evolution of this field. And I'm a stroke neurologist myself, and I have all my career felt inadequate compared to the cardiologists who were 20 years ahead of us. But I think we're beginning to catch up, and we'll hear about that. And so Brendan, as I said, is one of this team. We have a telestroke service that covers all 14 hospitals within the BJC healthcare system. And one very important purpose of that telestroke service is to screen out candidates for thrombectomy, which we'll be hearing about. And so with all of the patients that feed into this system, we treat about 250 thrombectomies a year, and that number is growing every year. So with that, let me introduce Dr. Brendan Ebi, who will be talking about the latest and greatest in acute ischemic stroke.
Wow, thank you guys. Thank you for that introduction. I'm really excited to be here. Let's see if I can, yeah. So I'm Brendan Ebi. I am an assistant professor in neurology, but I am our current only interventional neurologist. Sounds like there's a little feedback on the mic, so I'm not going to walk around too much. And I appreciate that introduction. I know there was a disclosure slide just briefly, and in ethical transparency, I do give some talks about these procedures to some of the device companies, or specifically teaching fellows on behalf of or funded by some of the device companies. That's not going to influence the talk here. I don't really care about the devices here. I really want to get you guys excited about some of the breakthroughs in stroke over the last decade. So I put some objectives on the slides here, but really what I want to do is walk you guys through really the last century, but especially the last decade, and how that's really overhauled both neurology and stroke. And so I've already gotten a little bit of an introduction from Dr. Lee, and he was spot on. But I'm a neurologist by training. I did my fellowship away from here, but I did residency here at WashU. And I was an intern just over a decade listening to Grand Rounds in the same auditorium. And it is really incredible kind of the things that have happened over the last decade. And I'm really honored to be able to come back and share that with you guys. So I remember, sitting in those seats on the other end, and I didn't think that I'd be the one down here giving the talks, but I'm glad to be. So this is kind of the photo that I wanted you guys to know what we're dealing with right now before we jump back to how far we have really come. This is our angiography suite. In fact, we have a new one, shiny, up in the Parkview Tower with modern equipment just like this. But we've refined a technique, just like catheter angiography for cardiac disease or other things, where we're able to have exquisite detail of the blood vessels. This has been developed over decades, as you can imagine, mainly as an imaging technique, but obviously the launching point of a number of interventions. And it's really had to take essentially a century of refinement to be able to get to where we are, to be able to treat stroke. I mentioned with radiology, I'd say they developed the technique, over the early part of the last century into the 70s, 80s, and then it was really co-opted by neurosurgery and forced forward as an intervention tool. A lot of you guys probably know about coiling aneurysms and other treatments from inside the blood vessels, but in that same sense, neurology has been really late to the game utilizing this technology, and specifically for ischemic stroke, which is the big focus here. But I do have some pride just knowing that the original cerebral angiography was developed by a neurologist. Igaz Muniz, he's a Portuguese neurologist that started this about 100 years ago. In the 1920s, he was injecting strontium bromide directly into patients' carotids and taking x-rays as a novel imaging technique. Now, he refined that over multiple failures, and in the 20s, you can imagine what a failure injecting contrast material into somebody's carotid directly looks like. But he did publish a lot of papers that really set in motion this as an imaging technique. And he won a Nobel Prize. Not for this. He won it for another procedure, the frontal leucotomy, which we now know as the lobotomy. So he's kind of a controversial person, but he really set things in motion for what I do today. Fast forward for 50, 70 years, into the 1970s or later, this was really just an imaging technique, and it wasn't even about the blood vessels. It was about the rest of the brain. So this was before CT, this was before MRI, and a lot of what we're able to diagnose now makes many of these techniques kind of superfluous, but it was all about looking at the blood vessels and really where they were going wrong. So here's an example of, an AP and lateral X-ray with an injection, and the arrows are kindly pointing out, some sort of space-occupying lesion displacing the blood vessels from the skull surface here. This was the best diagnostic tool at the time. It fought against pneumoencephalography. So, at this stage, when I was a resident, I felt this was a very barbaric approach, but it was a key in diagnostic information where they would drain out a patient's CSF, fill it with air, spin them around to make sure the whole ventricular system had air, and then they would take the same X-ray to see if there was any other kind of displacement. So this was a novel technology. Can anybody guess what this is under the skull here? Nowadays, if we just get an MRI, it makes it really clear that this is just bilateral subdural hematomas. But back then, it was very difficult to discern. So this was a really effective tool. Another example of the same thing would be, here's another angiography, AP and lateral. So we're going to start with an AP ICA injection. This one has digital subtraction. So we're even able to take away the skull, really see the course of the blood vessels. And you can see the anterior cerebral artery kind of arcing right up the middle. Should be a nice straight line, but here it's bowing out quite a bit. So this is vascular displacement. If we do that lateral view of kind of a similar thing, what you see is a bunch of branches from the external carotid, particularly the middle meningeal artery, filling this hypervascular territory. Any idea what might be getting blood supply from the meninges and displacing things? Well, another MRI makes it very simple. This is a meningioma, a frontal meningioma, displacing those. Back in the day, this was a really important diagnostic tool. In fact, just one other marker, a little trivia point that you guys probably should know is related to The Exorcist. They have a beautiful graphic scene, let's see if it plays, of a carotid angiogram. It's, again, a direct carotid puncture. You see her flinch the whole time to bring all the machines in. And even at this time, they were only looking for vascular displacement, maybe a tumor that could explain her problems. The Exorcist is also a very important piece of film that you guys should all be familiar with, mainly because it's supposedly based on a case of an exorcism of a boy here in St. Louis, exorcised by the Jesuits over at St. Louis University. So there's a very good chance that this actually represents what we were doing here at Barnes Hospital back in the 1970s. Fast forward to today, modern angiography is now a much more dynamic and interventional tool. So we're able to diagnose things, mainly of the blood vessels, but we're also able to treat them. So that means provocative testing. And that also means going in with our catheters and treating things like aneurysms. Here's a great example from one of my colleagues of a patient that came in with subarachnoid hemorrhage and multiple saccular aneurysms. So you can see this ICA carotid aneurysm, so the tip of the ICA right where it bifurcates. And then this is an anterior cerebral artery, ACOM aneurysm. Bringing our tools up, we're able to coil both of those off, and then with repeated injections, you can see no filling in those areas. I mean, these are essentially excluded. This patient is now protected from subarachnoid hemorrhage. This is probably old news to you guys. We know that the neurosurgeons can do amazing things with this, the radiologists as well, pioneering a lot of these techniques. So why is a neurologist talking to you guys about this? Well, first of all, I did the same training as all my colleagues, so you can get to this through any of these different avenues. We have a neuroendovascular intervention fellowship here and at most academic institutions across the country that requires a diverse background, so neuroradiology, vascular neurology, or neurosurgery. And we're really proud here, as Dr. Lee has mentioned, of having a very diverse team. We have 2 neurosurgeons, a radiologist, and then I am still the first and only interventional neurologist. And I've been back at WashU for about 4 years as faculty. A big part of that was to expand our footprint in thrombectomy as we've opened up an additional site. So I'm also the stroke director at Barnes Jewish St. Peter's Hospital. And so why was neurology so late to the game? Well, the toughest nut to crack has been ischemic stroke. But this has also been kind of the big one that we've been trying to go for a while. I normally have to gloss over the slide. My talk is to neurologists, and I don't have to convince them about the impact of stroke, but I'd really like to take a minute to really tell you guys about it because, neurology is a subspecialty, and a lot of what we do probably dwarfs in numbers compared to what, the average nephrologist and pulmonologist deal with, but this is our bread and butter. It is the 4th leading cause of death in the country. And even in COVID days, it was the 5th leading cause of death. And on top of that, it has an outsized effect in disability. So it costs billions of dollars in disability. A lot of people die from stroke, but there are a lot of people who are disabled, who can't work, who need constant health care. So it actually has an outsized impact, kind of similar to Alzheimer's disease, which is another one that we deal with a lot, where people are still living, but not necessarily the same functional. So any kind of small degree of impact that we can do here can have, demonstrable effects. And then I always love showing this graphic from the CDC. This is the stroke belt, if you will, just the super high density in the southeast of stroke. And of course, Missouri and St. Louis fit into that. We're kind of the buckle of that stroke belt. So with that, we could really make a big impact here. And just to clarify, we're talking about ischemic stroke. This is another great graphic, because you guys have all heard about coiling for subarachnoid hemorrhage. Subarachnoid hemorrhage here only accounts for about 3% of what we call stroke, or what you guys might write in your notes as CVA. But ischemic stroke, that's the bulk of here. So 88% of things are ischemic stroke. And when we're talking about ischemic stroke, we really just mean, thrombosis, occlusion of the artery, infarction. And so to back up again, kind of a trajectory, how am I here? When I was in medical school, a lot of the advice was kind of similar to this cartoon. I had to include it. It's kind of the representation of, the typical neurologist, the armchair intellectual. So for you in the back of the room, it's a long-standing kind of conversation, but basically he's opining about the localization with crossed findings and ataxia of a lateral medullary stroke, a Wallenberg stroke. But the final question at the bottom is, what can you do about it now? And he said, nothing. Still fascinating, right? I also juxtapose it to the neurosurgeon, whose whole scene here is just about how he can be busier and busier. He's only about doing. He's not about thinking. And so classically, neurologists have been felt not to be able to do anything, and particularly in stroke. I'm surprised that this still is such a prevalent idea, because it has been now 30 years that we've been able to do at least something for stroke, and that came from TPA. So it's almost exactly 30 years ago that this was the pivotal trial published to allow us to intervene at stroke. And as you guys know, this is giving TPA, and now we use a different thrombolytic, tenecteplase, but the same idea. Here it's activating plasmin to allow dissolution of fibrin, active clot breakdown in stroke. And when this came online, we had to go from those armchair intellectuals to an entire new process. We were evaluating patients very quickly. So what you guys probably know is the code stroke, and forgive the graphic, this is the best that I get ChatGPT to generate. But this urgency down to the CT scanner in the emergency room, this was not a thing before, the early, mid-1990s, and it required a whole system overhaul. I mean, a lot of places didn't even have a CT scanner down in the ED, or they were just getting online with that, maybe for trauma, but to focus screening and evaluation for stroke was a novel concept. But this is kind of where we languished for the last 30 years. I mean, this was the only tool that we had, and it wasn't the best tool. There are a lot of restrictions. So I guess let me step back a little and just talk about this was a really important trial that also brought out a couple of very important points to our kind of stroke conversation. So some other basically definitions that I want you guys to know kind of going forward. We talk about the stroke scale. So this brought that forward. This is an evaluation of stroke. It's a point scale out of 42. Nobody gets all 42 points, but above 20 is a very severe stroke. We consider above 6 at least a moderate stroke. So you've probably seen the screening tool or maybe administered it down in the emergency room or other places. On top of that, this trial also kind of introduced or cemented in the vernacular a way to measure disability. And this is going to be important when we're talking about the evidence for the trials going forward. But we use something called the modified Rankin scale. So basically, this is a 6-point scale, technically 7 points because you can get a 0, of how disabled somebody is. It's relatively simple. 0 is no symptoms, 6 is dead, and then 1 through 5 is more disability. But a key focus here is 0, 1, and 2. 0 is no disability, 1 is slight disability. You're able to do everything you need to do. Maybe you got a little arm numbness, maybe you've got a little bit of slurred speech, but it doesn't impact you. 2 is slight disability. You're not able to do everything you used to do. Maybe you can't quite work, but you can still take care of yourself. You can be at home on your own. You could live on your own. Everything below that means you need substantive help. 3 means you could still maybe walk unassisted, but maybe you can only go a few hours by yourself at home. 4 means you need pretty consistent care. 5 is bedbound. And then, as I mentioned, 6 is dead. And so here, this kind of cemented this language to disability. But this is really kind of the battle that we're dealing with. We think it's good to get somebody back to being able to do their normal activities of daily living. We're not talking about like getting them back to work necessarily, just because of how disabling this disease can be. So getting back to TPA, it was revolutionary. It changed a lot of our systems, but it has a number of drawbacks. As you guys probably know, it's a very tight time window. It has bleeding risks. But the other issue is that it's not always effective. And the short story for this paper that I put up here, and citing some of these percentages, is that the larger the clot, the harder it is to break it down. So in the internal carotid artery or the basilar artery, it's only a 4% recanalization rate. I mean, that's pretty terrible. Even in the M1 segment of the MCA, it's only in the 30s. So, 2/3 of people don't have recanalization. And when I'm talking about that, just a quick anatomy refresher. This is an AP angiogram of the skull. So I have the unsubtracted over here so you can get your reference points. But the carotid artery comes up here. This is the intracranial carotid artery. It's pierced the skull and it's supplying the brain. You have the middle cerebral artery out to the side, the anterior cerebral artery up the middle. And then we're talking about the large vessels, so the proximal vessels. So down here, the M1 segment, kind of the horizontal segment of the MCA, and the A1 segment is the horizontal segment of the ACA. The nomenclature is pretty simple. The further you go out and the more branch points you get, the higher the number is. M4 is the furthest out that you get. But ultimately, when we know blockages are down here at the bottom, TPA and TNK, are just not effective. And so naturally, you're like, well, let's think of another plan, right? You know, I'm probably a dumb brain plumber, again, another image from ChatGPT, but you know, why don't we take those clots out? I mean, cardiology has been doing it for 20 years. It's pretty simple. You know, an open artery is better than a closed artery. Well, it's not for lack of trying. So I love showing this because it shows the evolution. Everybody's like, okay, you know, it took you 20 years to try what the cardiologist is doing. Not really. We've had IA, TPA, that started pretty much immediately after the trials. We had other devices, intravascular ultrasound, all of these different capture devices, but ultimately, all of the trials have been negative. And that was up until, again, when I was an intern sitting in these seats in 2014 and 2015, when we had our first positive trial. And then we had a watershed year. So in 2015, we had 5 trials all come out positive for thrombectomy. And this was huge. You know, obviously, we were shouting it from the rooftops, overhauling our systems to try and treat people. But they put it together in this meta-analysis of individual patient data, so very high quality data. And just to go through to understand kind of why we were so impressed with this. Again, this was the outcomes data from taking people for thrombectomy. So this was large vessel occlusion, so the proximal occlusions under 6 hours, if you can take them and pull the clot out. This is based on that modified Rankin scale that I have over on the side here, and then they show this ordinal shift analysis. So basically, for the patients in the control population, nearly 20% of them died, 18.9%. And on top of that, only 5% got by with no symptoms, like if you didn't do any treatment or just maximal medical management, whether or not they got TPA. And so for a good outcome, so you know, just slight disability, only a quarter of them, 26.5%. By taking these patients for treatment, we could double that. And so half of the patients, 46%, so not quite half, would have this decrease in disability. We decreased deaths, and we shifted all of the scale over to better outcomes. And with that, it was shown to be an extremely powerful tool. If you've been to any of these thrombectomy talks before, you've probably heard us use the term, you know, talk about the number needed to treat. The idea here is how many patients do we have to take for thrombectomy to make a difference? Well, the answer was very few. So to get somebody down to, you know, independent, it was only 5 thrombectomies, and we could guarantee one of those patients would do better than they would otherwise. And actually, if you're just talking about shifting them down some disability, it was less than 3 patients that we could take and improve their disability. And this effect doesn't happen in medicine. I listed some common things down here. Shocking somebody in cardiac arrest is the only thing that I could find close to this, 2.5. Some of the things that we hold as like stalwarts teaching in medical school, so aspirin during a STEMI, it would require 42 patients to give aspirin to prove that you prevented 1 death. And similarly, we have somebody who has an acute DVT, we rush to anticoagulate them, but it still takes about 20 patients to prove that you've prevented 1 PE with that anticoagulation. So this is a very impactful treatment. So we were very excited about all of this. And then just a quick breakdown on the same thing, we went and looked back to say, okay, but you know, is this across the board? And the short answer is it is. It doesn't matter whether or not you got TPA or didn't. These patients all had a shift to better outcomes. And then if you look at, you know, this chart here for just all of the effects, basically everything favors intervention. There are a couple of areas of uncertainty. So this is the low aspects. That means they came in with large damage from the stroke. So that's uncertain. Similar low stroke scales, that kind of crosses over here. M2 occlusion, so as you get further out, so smaller blockages. Those are kind of the areas that we weren't sure. And then there was also some debate about very young patients, although as you can imagine, that was a small group that had entered in the trial. So that set the stage for our current guidelines on thrombectomy. So what do I mean by the thrombectomy procedure? Well, it's actually pretty simple. Again, I had ChatGPT try and help me. It requires a substantial amount of coaching just to get something usable. But it's pretty simple. We, modified cell denture technique, we bring a catheter inside the artery, the femoral artery, we snake it up. So this is hooking over the aortic arch. catheterizing one of the blood vessels. So this is the left common carotid artery. And then we stage an attack on the brain using essentially 2 different techniques. And again, as I tell my patients, it's pretty simple. We developed a stent retriever, which is just basically a stent that remains attached to the wire. It integrates the clot and you can pull it out. Alternatively, you can bring just a big catheter up, an aspiration catheter up, and try and suck out the clot, essentially. Aspirate on it and either ingest or cork the clot. And then a lot of people use a combined technique where they put a stent retriever and the aspiration catheter up. But at the fundamental, that's all that we're doing. We're getting to the clot and we're trying to use one of these tools to pull or suck it out. And what does that look like? Well, it looks like this. Same case, AP lateral of the, or sorry, just AP of the internal carotid. You can see the stump of the distal carotid here. And after revascularization, a dramatic recovery of the MCA and the ACA. I love these pictures. I love showing them to patients because I think you can really fundamentally understand what we're doing here. You know, it's not subtle. We're obviously getting a lot of blood flow back to the brain. And this is what the clot looks like when it comes out. A couple rapid fire, the same thing. You know, even a distal MCA, we get all these branches back. This person had a pretty large anterior temporal, so there's still some filling there, but was quite disabled with this territory missing. Same thing on the other side. You have a proximal M1, and we can recanalize that whole territory, and then another distal M1. And with all of those things, you know, they all look very similar because it is a dramatic recovery, you know, and that's where we really got our benefit. The feed-forward question becomes, you know, why are we only taking these patients, and what did we learn from these trials? Why was it positive in 2015 when all these trials before were negative? Well, these are some of the key caveats. So the devices are better. We got better at treating them, but the main one was better selection here. So before this, we didn't even prove that they had a blockage. So now we've added CTA to the algorithm to prove that they have an occlusion. So this is an M1 occlusion on the CTA. So we're selecting for those patients. We also learned from those trials, right? They have to have a disabling stroke, more than, you know, stroke scale more than 6. You know, they have to have a, you know, a good baseline. We can't make them better than bedbound if that's where they started. But they also were not supposed to have much in the way of a large stroke. So we have to have brain that we can save when we take them. And then this was also within 6 hours. So this is where our guidelines shifted. I think this was in 2017 that they released an update focusing on this, you know, revolutionary treatment and pushing it forward. And they highlighted a number of caveats here that I just pointed out about, you know, how you're supposed to select those patients. So this was great, and this was fundamental to all of what we did. But just go back to that number needed to treat. Again, if you've listened to anybody else talk about these thrombectomy, we're really proud of this number, but actually, some of us might be a little embarrassed by this number. I don't know if we like it as much. And I'll tell you why. It's too low. So if we're saying that we can take, you know, only 3 patients and improve one of them, then that probably means that we're over-selecting patients. That there are patients that are on the border that we are excluding because of this criteria, and we're really only going for the lowest hanging fruits, the people that we know are going to get better. We're not exploring kind of those fringe cases. So the real question over this last decade has been, how many more patients can we bring into this treatment and help with that? And so then over the last 10 years, we've been starting to work down this whole list of exclusions with a number of different trials to try and figure out how we can expand it further. So let's start with the obvious one, 6 hours of onset. Well, just within 3 years after this treatment, 2 trials came out, the DAWN and the DIFFUSE trial, completely upending that. So DIFFUSE 3 took it out to 16 hours. And this was, you know, a decent number of patients, and they could have, you know, basically the same amount of established infarct. So they could have a little bit of damage anyways. And then DAWN took them all the way out to 24 hours. It was a bit more restrictive, so it said that they didn't want very much damage because of the stroke. And this was all based on an imaging criteria on CT perfusion. So this is CT scans when you repeat it over and over to watch the flow through that vessel and see where it's delayed, an estimate of where it's infarcted already and where it's ischemic but not completely infarcted. So another way to select patients, but it did mean overhauling our systems again to add CTP to the CTA. But with this technology, we now can get patients who are 24 hours out from their stroke and bring them in and do the thrombectomy, and then we know that they have excellent outcomes. So here are the outcomes for those trials, same thing. In fact, we reduced morbidity to that good outcome in a similar percentage, 45% in Diffuse 3, 48% in Dawn. So these patients have the same outcome. But in fact, the control groups did even worse. You remember it was 26% on the early window. In these trials, it was 17 and 13%. So these are even more disabled patients, probably because they can't get tenecteplase or TPA, probably because, you know, it's, again, a severe disease. And so it's even more helpful. These numbers needed to treat are lower than what we had before. So, you know, this was good, but we wanted to go further. We extended the guidelines. They have all of these caveats based on CTP. But the next thing that we focused on was core size. So, okay, they come in and they don't have much stroke. Yeah, we can save a lot of brain. But what if they already have some stroke? Is it worth saving what they have left? And so this was a publication just 2 years ago that upended all of that. They took specifically patients with large core, so people who had already had a lot of damage, and enrolled them up to 24 hours. And what did they show? The same thing. There was a substantial benefit in outcomes. So the medical care group did very poorly, and the thrombectomy group, over double of them, we were able to get good outcomes. Now, I will point out that we are, you know, we're making these percentages a lot smaller. So only 20% of the patients treated ended up independent. But compared to 7%, you know, 93% of people being disabled with this, you know, we were helping a substantial number of people. And then also, there was a mortality benefit. You can see 40% of people with this much damage would die without this treatment. And we were reducing both death and disability with this. And this also kind of obviated a lot of that CTP conversation, because now we don't have to worry about how much core there was. We just know that within 24 hours, it's probably worth taking them, and we can help more people than we hurt when we do this. So we've extended the size, we've extended the time window. The next question is about location. So this was all ICA, M1, anterior circulation, large vessel occlusions. And so then the next big breakthrough was basilar stroke. So you guys might know about basilar, but I would contend that it's probably the most important artery in the body. I know our cardiologist would argue with me about the LAD, but the basilar, you know, perfuses our brainstem. It is a devastating stroke. So it has up to 80% mortality, depending on what study you look at. And on top of that, there can be some damage that some would consider a fate worse than death. So you guys know about locked-in syndrome. Basically, when you have infarcted, you know, your motor centers and your pons, you can't move your body, but you're fully conscious. Maybe you can only communicate by blinking or moving your eyes. You are a prisoner in your own body. There's a great book, if anybody's curious. It's called The Diving Bell and the Butterfly, about a gentleman who suffered one of these strokes. And then he told his story by transcribing the entire book letter by letter with blinking to his spouse at the time to describe, you know, what his experience is. So obviously a very methodical and difficult way to express himself. But, you know, definitely also a very clear target for patients that we want to help. Well, you've probably already read on the slide, there were 4 recent trials, and a little shift here, they're not even going for no disability. They're okay with, you know, moderate disability, that you need some help because this is such a devastating disease. But what we found was it did seem to help numerically. The first 2 trials were negative, but the second 2 trials were resoundingly positive with a similar number needed to treat. So we took it to a meta-analysis, and overall, the evidence strongly suggests that taking these patients with basilar occlusion also benefit from thrombectomy. So in that same regard, this is now expected treatment and an expected update to the guidelines. And one of those trials did also go out to 24 hours, and so it's likely, in our algorithms, we've fit those all together. So basilar arteries. A brief conversation, though, probably our first, I'd say, roadblock would be distal occlusions. So this is a really difficult one that we've been debating for years. So obviously the proximal occlusions we can get out, but the distal occlusions we can also go after, but it's kind of a risk-benefit proposition. There's more risk going more distally, more tortuous anatomy and damage to the vessels, and there's less benefit. By nature, these are smaller strokes. But we tried a couple of trials to prove whether or not it would. And just this last February at the International Stroke Conference, these were announced. I won't go through them in detail, but the ESCAPE-MEVO trial was a US-based trial enrolling all across the spectrum of occlusions, ACA, MCA, PCA, and it was one of our first main expansion trials that was negative. So it did not show an MRS difference. Distals was a similar trial out of Europe. They enrolled, again, up to 24 hours, and they had a similar, very extensive inclusion criteria. It also did not show any benefit. And so right now, this is one area that I think we have some equipoise that it doesn't make sense for us to go into these distal occlusions. M2 in a lot of these were kind of excluded, so that's a weird place of equipoise. Further trials are coming out to try and evaluate if there are select patients in this group, but right now that's one place that we haven't really shown that. And so then I guess the last one, just to talk about pretty briefly, and I'm checking my time here, but we're good, would be age. Well, the main thing here is, I almost glossed right over low stroke scale. This one is a little more difficult because it's just ongoing right now, but I do want to have a call out that we have an ongoing trial. So we know LVO can present in strokes, but there are a number of patients with low stroke scales that also have a large occlusion. Should we take them to the cath lab, or are they, quote, too good to treat? There's some concern that some of these patients deteriorate early. We don't know the answer to that, but this is a call out for some of the great work that my colleagues on the research side are doing. So the NIH has funded this STEP platform trial, a unique type of trial where we have multiple arms kind of sharing some of the control data between the patients to be able to enroll in different trials kind of simultaneously. And one of those arms down here that I'm highlighting is low NIH stroke scale. And so we are just getting that back online to enroll in. Another arm, as I mentioned, would be those distal occlusions. There's still some ongoing data to try and collect to figure out those. So a really an incredible way for us to accelerate even more of these questions to answer. And then I had jumped ahead a little bit, but just to talk about age again. Well, this comes down to pediatric thrombectomy. The short story is I don't have a lot of data for you because we're not going to ever really generate a lot of data. This is a really rare disease in kids, as you can imagine. And then it's going to be really hard to randomize. We'd need a huge amount of infrastructure, but on top of that, based on all this data that I provided you, you could imagine that most of us don't feel like we have a lot of equipoise for a kid in front of us who has a large stroke. So, in that same kind of question, here's an example of a case that I actually dealt with, a 14-year-old that came in after 7 hours, slurred speech, left-sided weakness, numbness, stroke scale was 8, and then they were concerned for a basilar occlusion with evidence of a pontine stroke. Would you take this patient? Would you refer them? Would you consider it? We definitely did. So I took him for angiography. This is his basilar occlusion, vertebral artery coming up. This is the contralateral, the distal left vertebral artery. But the basilar just stops. Fortunately, we were able to take one pass, open up the whole artery, and pretty much immediately his disability improved. His stroke scale dropped to 3, and he was able to be discharged home without extended inpatient rehab. So he's been doing really well. So this is a call out to my colleagues over at St. Louis Children's. We have an amazing pediatric stroke program. They are, cutting edge, giving, I think, the first TNK in the country to a pediatric patient. We've been partnering with them to offer this to the rare case that we need to. I actually did a pediatric case maybe 2 weeks ago. Just a unique environment here. And so then just briefly, a little question about kind of where else are we going. So this has all been happening in the last 10 years, since 2015 until now, and we're still refining this. So obviously we still have some questions about distal occlusions, but the devices have been expanding rapidly. We need to get this out to more people, so systems of care, and then adjunctive pharmacology. So that's a big question here. You've got the devices, you've got the vessel, but is there anything else that we should be doing? And this is probably the hottest topic. This is where I think we're going to see the most literature. In fact, if we go back to ISC, they had identified that a lot of these patients, even if we open up the artery, don't recover very well. So is there more we can do, like intra-arterial thrombolytics or other pharmacologics to improve that outcome? And they presented multiple trials that were suggestive of it. So this is great. And this is a photo I took at the International Stroke Conference. Only 3 of these papers have been published to date, but really attacking this. And they found that pretty much all of them, outside of one, or 2, these post-TNK and post-UK, they were positive for improving patients' outcomes. Now, there were some caveats. Their primary outcome was excellent outcome, so that means slight or no disability, not good outcome, and just about none of them demonstrated benefit on our standard good outcome metric. The other thing is that we haven't figured out what actually to give patients. So 3 of them gave TPA, 2 of them gave TNK, 1 of them gave urokinase, which is not something that we ever really give. And then the doses were very different. Whether or not they allowed patients to get IV thrombolysis was also of debate. So we have a lot of nuance to figure out exactly how to deliver some of these extra therapies, but I think that's going to be really kind of the upshot of the next round. And so then, in this last 10 years, this has been really kind of a revolution in stroke, and it has also affected kind of how we manage things here at WashU. I think this was alluded to a bit by my chair, but the algorithm for stroke has gotten quite a bit more complex. This is the actual algorithm that we give the residents in their cards to reference when they are trying to make a decision on an acute stroke patient. They need to evaluate, onset time, whether or not they have an LVO, what their stroke scale is, whether they should perform a CTA or CTP, whether or not they could get TNK using some of our wake-up protocols with hyperacute MRIs. 30 years ago, we couldn't do anything, and even 10 years ago, the only decision was whether or not you could give TPA. So, this has gotten more complex, but very exciting. But to assist with that, we've had to overhaul all of our systems. A call out to Derek Holder. He's one of my partners in stroke, but he's spearheaded a lot of this. We have developed a hyperacute stroke team. So we have neurologists stationed in the ER every weekday, Monday through Friday, 7 a.m. to 5 p.m. to assist with this. On top of that, he's developed a regional telestroke network that expands to our entire HSO, so all 13 BJC facilities, and there was at least one Ozark Medical outside of our system where we provide 24/7 triage and decision support for the emergency room doctors to try and figure out how to treat these patients. On top of that, we are helping the community because, as he pointed out, and this is a slide that he gave us for our last St. Peter's survey, 84% of these patients are then able to stay close to home and at their hospitals. So we're also helping their families, helping healthcare costs. And with that, we're also trying to expand thrombectomy even further. So as I mentioned, I'm stroke director of St. Peter's. That's out here in St. Charles County. All the red dots can help represent other BJC facilities throughout the area. And we're not the only game in town. The other stars are some of the other stroke intervention, comprehensive stroke centers from some of our competitors. So we're expanding across the region to try and bring this care to other patients. And then we definitely have a vested interest in trying to grow this to even further facilities across the region. Basically, bring the treatment to the patients where they're at. So with all of this, we have been trying to answer this call of the acute care for thrombectomy and bring it out to the community as quickly as possible. So I guess I've talked quite a bit, and I want to keep us on time, so I'm going to leave it there. But my final thought here, I think this is exciting. I think this is revolutionary. I mean, I would say that this is probably going to be one of our biggest medical breakthroughs of the century. But I think it's also going to affect a lot of the lay of the land of not just neurology, but medicine in general. Your ACLS now talks about identifying stroke and large vessel occlusions, and that comes down to this being one of the most powerful, but also most time-sensitive treatments in medicine. And then with this, we're looking forward to being able to treat all types of cerebrovascular disease. I know that this is in the acute care setting. You're probably not dealing with this large vessel occlusions, but even if you have questions in the clinic, whether it's cerebrovascular disease, atherosclerosis, aneurysms, AVMs, please reach out. We want to be a resource. I can see them in my clinic. I've got a clinic at St. Peter's and the CAM. So I put my email, my phone number, but if you want my cell, just find me afterwards, and I'm happy to give it to you.
Someone in the back.
In cardiology, we do hypothermia of certain muscles. Have you considered that as part of your algorithm to use hypothermia to give you more time to save brain tissue?
You're talking about hypothermia specifically in cardiac arrest or in acute cardiac syndromes. Because we have discussed many methods of neuroprotection, I guess I would say that, both pharmacologic and other interventions. Specifically for hypothermia for intervention, I don't think that we have any specific trials. Obviously, this is new to be released, but a lot of either our pre-hospital or inter-hospital management has not been able to be adjusted. So I think that'd be a very difficult trial. Obviously, a lot of what we're trying to do right now is just getting the patient to the cath lab as quick as possible for these identified strokes. There might be a role for that in post-procedure care, just as I was talking about. We don't really know what to do with these patients after we've opened the arteries, but I don't know any evidence on that. That would be a really interesting study.
I preface this that I'm an obstetrician gynecologist, and it's argued I know nothing about medicine. So this week, the FDA removed the black box warning on estrogen. We have for 30 years denied women estrogen therapy on the basis of randomized studies that were not controlled, particularly for age. So I just mentioned, you mentioned that as part of this. If you don't control these randomized studies for age, then you're kind of ruling out. But in particular about estrogen and women, they're not stratified for gender. And the evidence is, well, let me preface also that you're talking about ischemic stroke, which is approximately 10%, and tend to be the milder stroke. Hemorrhagic stroke has the highest mortality rate. And I could not find studies on estrogen and hemorrhagic stroke. I did find a few in rats, on male rats, using estrogen, and about the transition from ischemic to hemorrhagic stroke. So in the reports clinically and academically, I find we do not distinguish between the mortality aspects of hemorrhagic stroke and the more common aspects of ischemic stroke. And now we have removed the black box warning, and we have no clinicians, no physicians trained to give estrogen to menopausal women.
That's an insightful comment. So just, I guess, to repeat, do we have anybody online?
Yeah.
Yeah, so to repeat for the folks online, our obstetrician here has pointed out that the FDA has recently removed the black box warning on estrogen, obviously with concern for thrombotic events or stroke. And, to point out that a lot of what we're talking about here is ischemic stroke, which is the dominant form of stroke, but hemorrhagic stroke is also very disabling, and depending on the study, I would agree that has a higher incidence, overall incidence of mortality. Large vessel occlusions notwithstanding, being obviously selected for the most severe ischemic occlusions. But the feed forward there is that there would be a risk of, an epidemiological increase in thrombotic events, particularly in women who might get this therapy, and kind of how we handle that, and I guess the education aspect on that. I would completely agree that, that's a concern. That's something that we have to counsel our patients on. It's a lot more difficult, I feel like, for a physician in your position than mine when you're counseling for the primary risk of one of these thromboses. If a patient has never had an event and they have a small but real chance of an event, versus when I get to see them in my clinic where they've already generally had an event, and I can tell them, well, obviously you're a high-risk patient and we shouldn't be going down this pathway. And so I do think that probably needs a systematic rethinking about how we educate, particularly the people who are prescribing it on the forend, to counsel those patients. I don't necessarily want to restrict an important therapy just based on a risk of complications, but I think we need to understand how to manage them. And then I would also speak that I don't have a lot of experience with hemorrhagic disease, particularly hemorrhagic strokes with estrogen therapy. So, that would probably be something that will have to be elucidated at the population level.
Yes, we have someone in the back.
I'm not a doctor. I work in clinical research for management. And I have a question about the studies that you showed early on with the pretty good data. How are the control population data collected? Is that just people who maybe didn't have access to the intervention at their hospitals, or?
All of the trials with data that I presented were randomized controlled trials. So they were specifically randomized to intervention or maximal medical management. At the time, there was an incredible amount of equipoise, especially in 2015, because no trial had proven efficacy of thrombectomy. So many of the physicians didn't have an ethical concern about randomizing to medical management because we hadn't proved that this helps people, and there was some concerns that we were just hurting people. That was also true with a lot of these other ones because they were excluded from the other trials. Although I will say, as the evidence mounted, it has been more difficult to maintain equipoise and have the interventionalists willing to randomize patients. A good example of that would be these distal occlusions. I mentioned very briefly a specific caveat where there's the M1 occlusion, the proximal middle cerebral artery, and the M3, M4, which are the distal arteries, but then there's a middle ground of an M2, which patients tend to be quite disabled from, but it is also more distal and was excluded from the primary trials. Well, for a lot of these distal trials that I showed, there were plenty of reports about centers who weren't enrolling those M2s because they did not think that that was ethical. They felt that these patients should receive the treatment. And unfortunately, now that the distal trials are negative, we're still left with a gray area of that in between. So, I think your question was, how was this collected? And I'd say it's a randomized trial. And I inferred from that, is there a consideration over, how that data is represented, whether it could be biased, or if it's fair to continue to randomize in the future. And that would be kind of an example that I have about how this might be difficult to get some of this data in the future. Let me follow up. Do you have any follow-up question on that?
Yeah, I guess, is this widely accepted now that the intervention would be the standard of care?
I think, yeah, especially nationally and for most in international centers, that and particularly in the primary treatment, so the early window less than 6 hours, and making the other criteria where the stroke scale is greater than 6 and there isn't a lot of core. We have level 1 meta-analysis data supporting that, and just about everybody agrees. Some of the other ones, depending on the national health systems, they haven't consolidated around it. So say large core data, that is the one where a lot of damage has already been done from the stroke and whether or not to take them for thrombectomy. There's still some debate, whether or not certain countries or health systems feel like their population was adequately represented and it could be translated. But I would say that for most here, there is consensus, up to 24 hours and large core. There aren't, at this stage, for almost all of them, they've been supported by multiple randomized trials.
All right, thanks everyone for coming to Grand Rounds.